Welcome to SLP Nerdcast. I'm Kate.
And I'm Amy, and we appreciate you tuning in. In our podcast, we will review and provide commentary on resources, literature, and we'll discuss issues related to the field of speech-language pathology.
You can use this podcast for ASHA CEUs. For more information about us and CEUs, go to our website, www.slpnerdcast.com. You can find permanent products, notes, and other handouts. Some items are free, others are not, but everything is affordable. You can go to our website to submit a call for papers to come on the show and present with us, and contact us anytime on Facebook, Instagram, or at info@slpnerdcast.com. We love hearing from our listeners, and we can't wait to learn what you have to teach us.
And just a quick disclaimer, the contents of this episode are not meant to replace clinical advice. SLP Nerdcast, its hosts and guests do not represent or endorse specific products or procedures mentioned during our episodes unless otherwise stated. We are not PhDs, but we do research our material. We do our best to provide a thorough review and fair representation of each topic that we tackle. With that being said, it's always likely that there's an article that we've missed or another perspective that we haven't shared. If you have something to add to the conversation, please email us. We'd love to hear from you.
Before we begin in today's episode and welcome our guest, we have one quick housekeeping item. And that is that this episode is releasing in February 2021, which we have deemed Funding February. Isn't that sound fun? So we're nowhere near as cool as NPR. But we do mention in our intro at every episode that our podcast in general is brought to you in part by listeners like you. Individual support from our listeners keeps SLP Nerdcast going, and it allows us to keep our CEU prices super low and keeps the podcast ad-free. So if you are able, please consider going to our website or social media pages and contributing. If each one of our listeners contributed $1 or $2, we would be able to cover our costs for an entire year. And that would allow us to keep access to the library of free episodes that we have. It would allow us to keep our podcast ad free, and we'll keep the prices for ASHA CEUs as low as buying a cup of coffee.
Fancy, delicious coffee.
Fancy, right. 1 cup of fancy and delicious coffee. This is something, removing barriers to continuing education is something that we are very, very passionate about. It's part of our mission statement, and we would not be here without your support. So Funding February, make a contribution if you are able. Thank you so much. So now that is out of the way, today we have the great pleasure of welcoming Mike Bright. Welcome, Mike.
Hello there. Thanks so much for having me.
Mike, you are here to discuss differential diagnosis in childhood apraxia of speech. And before we get started, can you tell us a little bit about yourself?
Sure. I think like many, I started down the road knowing that I liked working with kids, did some teaching. I was a special education aide where I learned about some ancillary services that kids enjoyed or didn't. And went from there to get my master's in speech-language pathology. Throughout that process, I was definitely most drawn to speech production and all of the components involved in speaking successfully or intelligibly. I went on to follow that interest when I worked at Children's Hospital, Boston Children's Hospital, where I was for more than 14 years, and was fortunate there to be encouraged to really specialize and follow my interest to learn even more about speech. The problem-solving aspect of what might be different about kids' speech, trying to find clues about what might be most impactful, and making guesses, testing them out, and trying to really understand completely was something that became really motivating and interesting for me. I was fortunate enough to be selected as an inaugural member of the boot camp run by what was Kasana then, what is now Apraxia Kids, where I spent 3 days in Pittsburgh with 3 of the most amazing people in the field, all day, part of the evening, talking about this very speech nerdery that we're here to talk about today. It was amazing. It really was fantastic. And that really was another kind of launching pad for me to get even more into this area of practice. And I now find myself starting my own private practice, where I am focusing primarily on diagnostics, doing single session evaluations, often giving second opinions on the possibility of childhood apraxia of speech, and trying to really treat carefully questions around diagnosis, and questions around what types of treatment might be most effective for kids, and really living in this space of often not knowing, not being able to know for sure what's going on, a space that is understandably very hard for families to be in when they just want their kids to be better. They just want their kids to talk, kind of being with them through that. And also being an ally for service providers who are also understandably very confused when there might be 20 things for a kid to need to work on. And you could throw a dart and hit one of them, and maybe that's the one that you need to work on, or maybe I hope to be someone who could kind of weigh in on those questions and suggest some possibilities for what might be most important, and helping folks to understand why. So yeah, that's me in a big nutshell. I'm a big nut.
That's awesome. Well, we're so excited for this topic. We've had so many listeners write in. All of our regular listeners know that this is not our area of Amy and I's area of expertise. Amy knows a lot more about this than I do. And we are just so glad to have you. Amy and I had the pleasure of meeting you years ago when we actually saw you speak at another professional development conference. And I learned so much from listening to you. And I know everyone else is going to too. I was teasing Mike before we started recording about how brilliant he is and how I'm so excited to just share this with everyone. But before we get started, let's go quickly through our learning objectives for the day and then read our financial and non-financial disclosures. So learning objective number 1, describe one reason why differential diagnosis is challenging. Learning objective number 2, describe one reason why differential diagnosis is critical in providing appropriate intervention. And learning objective number 3, identify 4 components of an in-depth speech evaluation when childhood apraxia of speech is a possibility. Financial and non-financial disclosures. Mike Bright is the owner of Bright Speech and Language, LLC, which is his private practice. Non-financial, Mike is recognized by Apraxia Kids for advanced training and expertise in childhood apraxia of speech. Kate, that's me. I'm the owner, founder of Grand Bois Therapy and Consulting, LLC, and co-founder of SLP Nerdcast. My non-financial disclosures, I'm a member of ASHA SIG 12 and serve on the AAC advisory group for Massachusetts Advocate for Children. I'm a member of the Berkshire Association for Behavior Analysis and Therapy, Mass ABA, and the Association for Behavior Analysis International, and the corresponding Speech Pathology and Applied Behavior Analysis Special Interest Group. Amy Wonka's financial disclosures. Amy is an employee of a public school system and co-founder of SLP Nerdcast. Non-financial disclosures. Amy is a member of ASHA SIG 12 and serves on the AAC advisory group for Massachusetts Advocates for Children. I always apologize to people after this because that's just the longest, most boring, most dry nonsense, but the powers that be required that we read it. So
I feel like you're just getting really, really solid with that fluid delivery of all of that information. Well done. Well done.
Thank you. I'm just glad it's behind us. Okay. Yeah. Moving on to the fun
moving
stuff.
along to the exciting stuff. So Mike, we've had a number of listener questions on this topic. Could you start us off just by giving our listeners a definition of childhood apraxia of speech, maybe telling us a little bit about differential diagnosis, what you mean by that?
Sure. Differential diagnosis is essentially a fancy way of acknowledging that there's many possibilities that might explain for child-specific symptoms. I don't know for sure, but I feel like in a more medical model, or a doctor might be considering maybe it's X or maybe it's Y. And with a comprehensive speech eval, I'm rarely in the either or space, but more in the space of trying to understand how much evidence I have for a child needing help with one thing versus how much evidence do I have that she might need help with something else, and weighing those possibilities as I am trying to recommend what might be most helpful. In terms of childhood apraxia of speech, I can read you the definition, which has got a lot of more big words in there, but I'll also try to explain my understanding of what that actually means too. If you look in the ASHA technical report from 2007, they are defining childhood apraxia of speech as a neurological childhood speech sound disorder in which the precision and consistency of movements underlying speech are impaired in the absence of neuromuscular deficits. So again, a lot of words, and I'll try to kind of pull out the things that are most important from my perspective. First, I think it's important to talk about the fact that we're talking about movement. We're not talking about language. We're acknowledging that there is a message that must be converted from an idea into symbols, and that's the linguistic component. There's all kinds of syntactic, morphological, phonological planning that takes place, but all of that is pre-motor. That happens before this sequence of motor planning and programming that is really seen as central to deficits when kids have a diagnosis of CAS. CAS being childhood apraxia of speech.
So I don't know anything about this, but I have a question for you.
Yeah.
So I work a lot with complex communicators, and this is my graduate school level knowledge here from almost 20 years ago, floating up to the top. You say that it's, in that definition you read, that we're really talking about motoric issues, not linguistic issues. And I will often come across individuals who have a variety of linguistic issues, multiple diagnoses, complex communicators who will also have a diagnosis of apraxia. Is it true that, quote, childhood apraxia of speech, so that actual diagnosis, stands without a linguistic component? In other words, if you have, decreased receptive language skills, can it also be childhood apraxia of speech? Can you have carry those two diagnoses at once?
Certainly, definitely. And I think even backing up further, it's helpful to acknowledge that we're operating on these models of how speech and language operate that are best guesses by people who know a lot more than me, but still there is likely more overlap than we're acknowledging as we talk about things separately like this. And it is true that you can, and I'll get into this a little bit later, but you can have a host of communication disorders with childhood apraxia of speech as one of them. And I think that's really one of the main reasons why a comprehensive in-depth assessment is so crucial when making recommendations, because working on motor speech might be a priority for a child, or working on pragmatics, working on representation, working on things like that might be precursors. Working on readiness might be precursors before we get the opportunity to really focus on this small area that I'm going to be defining as motor planning and programming.
Thank you for answering my question, Professor.
Okay, well, geez, Professor. Oh boy. Okay. You guys have full permission to stop me when I get into professor mode, because that is not this. This is not that.
Anyway,
disclaimers throughout.
Moving on. I was being sarcastic, but I appreciate your answer, because that's always been a big question of mine, working with complex communicators who carry multiple diagnoses, and trying to, like you said, throw a dart and figure out what to work on first. I think it was helpful for me to sort of flesh out the difference between childhood apraxia of speech and where that line might end and, start and stop with some of these other, with more complex communicators. So thank you for answering my question.
Well, and I'd imagine that that's part of this differential diagnosis component, right? Is trying to tease out some of those bits. I don't know if you want to talk to us a little bit more about what some of the challenges are. I mean, I think Kate already touched a bit on some of that. It's hard to say. There's a lot of things that could be overlapping. What are some other challenges that you see when somebody comes to you and you're trying to sort of tease out all of those parts?
Yeah. Again, I'm going to take a step back and try to explain a little bit more about what this little box that I'm living in is, and then we can talk about all the other boxes that are neighboring it, if that's okay. And because I think it is really important to understand better this area so that you really can see the scope of how many things are not this. If that makes sense.
No, it makes a lot of sense.
Okay. All right. So let me take a stab at planning and programming and explaining those in a way that hopefully disambiguates these very similar sounding words. Sometimes I think of planning as strategies for movement and programming as tactics. I'll give you an example. If you are trying to catch a ball that's coming at you and you need to catch it, or else the planning or the strategies that you need to catch that ball involve the forward movement of your arms, opening your hands, and closing your hands. The programming aspect or the tactics specify which muscles actually need to do the movement and at what rate or velocity they need to move, with how much force they need to move so you don't crush the ball, the range of motion so that you capture the ball, and even the mechanical stiffness of the joints supporting the muscles that are needing to move. And what folks have found out that when someone has a deficit in one of these planning or programming areas as an adult, they can often identify areas of the brain that are specifically responsible for these distinct planning and programming boxes. So this is all to say that our job when trying to better understand how a child's planning and programming speech system works, we really need to be feeding input into this black box and analyzing what comes out of there, or what comes out of there, what the child is able to do with that input, so that we can be looking for certain characteristics, because we know that there's certain speech characteristics that can be best explained by those difficulties in motor planning and programming. The three characteristics that are identified as most likely to arise from a childhood apraxia of speech are token-to-token variability and disrupted co-articulatory transitions and prosodic differences or difficulties. And let me go into those a little bit more. Oh, yeah.
Well, I was just going to ask you to go into those a little bit more.
I've never heard of the first one.
So token-to-token variability.
I have no idea what that is.
Hey,
I have my C's. I just have never heard of it before. And that's okay, everyone.
It's a mishmash word salad. Like it, and I completely get it. Basically, token-to-token variability is a way of saying how consistent or inconsistent is a child's production of a single target. That target could be a word, it could be a phrase, could be a sentence. How consistent is it time after time? What we are interested in terms of childhood apraxia of speech is there variability in that movement between sounds, or does the child move between sounds very reliably and predictably? I'll give you an example of what might not be childhood apraxia of speech related token-to-token variability, and then talk about what might be. And I think that could be helpful too. My 4-year-old recently was talking about a picture of an ostrich, and he commented that I should look at its fail tethers rather than its tail feathers. Very cute. But he does not have a speech disorder, but I imagine that this difference He's never called them fail tethers before. And so it would be an inconsistency. But I imagine that this type of inconsistency arose from, oh my gosh, I just did it. Did you hear me? I just stopped and corrected myself. There it is. And I don't have a motor speech disorder, but what just happened there was somewhere in the transition of moving ideas into language, or somewhere in the moving of that language into motoric code, there was a mix-up. And so what would happen if I was in a speech eval is we would try to see if we could have that thing happen in certain situations more or less. Is there a support that I can give to make that happen less frequently? And trying to understand that. If a child was having planning and programming difficulties on something like tail feathers, one time it might sound like tay feathers. Another time it might sound like tail feathers. Another time it might sound like taffers. And what's different there is, I substituted some sounds here and there, but more than that, there was differences in stress, and there was differences in vowels. And those are the types of inconsistencies that I'm really interested in when I'm thinking closely about childhood apraxia of speech.
This is all news to me. I didn't know any of I think the inconsistency of sounds I knew, but the difference in prosodic stress, is prosodic stress a thing? Yes, that's a thing. The difference in stress and prosody, I did not know that.
Yeah, and I would call prosody an umbrella term that encompasses stress, intonation, and rate.
See, we're all learning here today.
Excellent. Professor Mike. But I think it's a good point, because of these three characteristics that ASHA has identified that we should be looking for when we're considering child apraxia of speech, this token-to-token inconsistency is one that people often over-focus on, in my opinion, because there are many ways that a child could be inconsistent, and only a subset of those ways might suggest motoric involvement. Does that make sense?
It does.
Okay.
I wonder if you can talk a little bit about, I'm just thinking through the diagnostic process, I'm thinking about, standardized assessments and non-standardized assessments that people might use. And I'm wondering, are these even things that are going to be adequately detected with some of the instruments that people are more like? I'm thinking about, I work in the schools. So in a school environment, you might do the Goldman-Fristow, you might do the Conn-Lewis, like based on the Goldman-Fristow results. But other than that, you might not even be looking for all of these pieces if you're running a standard speech battery.
Exactly. And there is no speech battery that has been proven to be sensitive enough to really be good at identifying childhood apraxia of speech.
And this is why informal assessment measures are so important.
Yep. And I'll talk about a few things that I like better than others. But I think what you'll realize is each of these is just another tool. And each of these provides just a little bit more information that I need to weigh against all the other pieces of information when I am trying to make this decision. And it is only because I had many years of doing this again and again and again with many people who have had similar questions that I've gotten to this level of identifying something like an inconsistency in stress marking versus an inconsistency that might be better explained by phonological planning. It is tricky. And I think part of being a good diagnostician is really fine-tuning your radar and knowing what you're looking for and how you might be able to find that.
But I think something that a question that raises for me, unlike some other diagnoses or labels that a person could get. If we're talking about a severe phonological disorder versus problems with motor planning, our intervention should look different, right? So,
Yep.
so that's why this is so
Exactly.
important.
Did you
the
just answer our second learning objective?
I don't know. No,
I think you did. Describe one reason why differential diagnosis is critical in providing appropriate intervention.
So yeah, tell us
Right?
more about that. Why is that?
Well, yeah, no, it is crucial, because if I'm trying to help a child learn how to retrieve and sequence phonemes in this premotor area, my intervention is going to be much different than if I am going to try to be working at establishing neural pathways that support movement gestures. And that might be another podcast in terms of knowing what to do for what.
Yes, that would be lovely.
Which
Mike
could
is
be
Are
very
you
fun.
agreeing to that on the air?
I was going to say you're laughing because we're so emphatically raising our hands with enthusiasm that you might come back, but that's okay.
I want to make sure I do the job that I was asked to do before we go into other things.
Moving on.
But yeah, and moving backwards a little bit, we talked about token-to-token variability, but the other characteristics that are super helpful in this area is listening for disrupted co-articulatory transitions, which is often a break in voicing as a child is moving between sounds. You never hear a child with a phonological disorder doing those. I have never heard a child with a phonological disorder doing that type of disruption. The disruption might be reflected or put forth as a prolongation, often through the vowel. So it sounds almost like the vowel is distorted, especially on a diphthong where there is movement between vowels, that movement becomes lengthened or unusual in some way. So that's something that's very important to listen for. And in fact, although vowel distortions are not one of these three characteristics that Asha identified as the top three things that we should be looking for, I would add it for myself as a fourth that is very that follows very close to those other three in terms of importance. And you don't need to have all of these three. You don't need to have each and every one of these three diagnostic markers to have apraxia. You could have one of them, and it could be significant enough and point strongly enough at this small area of motor ability that someone would be confident in saying childhood apraxia of speech, which again just points to how complicated the diagnosis this is. It's not a checklist. If you X and Y and Z, then childhood apraxia of speech. It's really this weighing of possibilities. How did that land? Does that make sense?
I
The
think
disrupted co-articulatory transitions.
Yeah. So far you've talked about token to token consistency. You've talked about interrupted co-articulation.
Yep.
There was a third one.
Yeah, the last one is differences or deficits in prosody, which is that aspect of controlling stress and intonation and rate. We do it automatically. It's a miracle that anyone can do it. I'm stressing when I'm talking I'm stressing syllables by making them louder and longer. And I'm not thinking about it. It's just happening. But there's a level of suprasegmental above the sound level motor control that's required to do these speech gymnastics that just happen naturally for so many of us, that when that is not something that a child is able to do, often what we see is children are devoting so many of their resources at establishing articulatory configurations that the prosody or the suprasegmentals get left out. So speech becomes very robotic and monotone, where stress is evenly and excessively distributed. And I can't even do it justice, but when you hear a child with prosodic deficits, it sounds so different and so unlike anything that you have heard before that it really catches your ear. So just such an important part of a speech eval to listen to that's not picked up by something like a Goldman-Fristow, that you really do need to listen to kids talk and to see how they are controlling their speech beyond kind of marking, do they have this sound in this word position or not? I think if it's okay with you, I'll go on to some of the other things that I'm doing in an evaluation.
That sounds great.
Okay. So one of the things that I'm really interested in doing is with any kid that I'm seeing is getting a good history. Some of the things that I'm really particularly interested when there's a question of childhood apraxia of speech is learning to know if the parents can remember what was babbling like when this child started to make sounds. Megan Overby and Sue Kaspari did a small pilot study where they retrospectively reviewed video samples from kids who went on to be diagnosed with childhood apraxia of speech. They looked at the videos of these children when they were younger and babbling. And what they found was not so much that children who went on to get a CAS diagnosis babbled or didn't babble, but more that children who did not get a CAS diagnosis were doing more variegated babbling. They were doing the type of babbling that moves between sounds more, which again kind of makes sense from a motoric perspective.
I was just about to say that makes perfect sense if when you think about the underlying deficits and neuromusculature that's involved. Duh.
Yeah, and oftentimes, even when asking like, oh, can you remember anything about babbling or early sound play? When Johnny was young, I'll hear something like, oh, he was such a quiet baby. And I don't really remember very much, but even that, just hearing that there wasn't a lot of this experimentation, I think can be just something that's important to remember, that there's not this same foundational established base of practice that so many kids just have naturally. Another thing in the history that I'm interested in learning about is, are there feeding and swallowing concerns? Is there age appropriate ability to blow bubbles or blow out candles, spit after brushing teeth, things like that. And as I'm kind of going through these things, I think it's important to note that there is a different motor system in control of speech movements and non-speech movements. So something like blowing bubbles is a non-speech movement, but what we know is that there's a certain subset of kids who have affected non-speech and speech motor systems. And that's an important thing to know. If a child is having motor symptoms in their speech and in their non-speech, the prognosis is probably poorer, and this child's going to need more support. So that's one of the reasons that I'm looking in that area. Yeah.
I was going to say, I mean, that just also makes sense to me because it's the same system working for two different functions. Would you say that that's a good synopsis of that?
It is. And it's the reason why when we're trying to support a child's speaking ability, we want to be doing it through speaking tasks, is because it is a different motor system responsible there. And confusingly enough, at least from my perspective, kids can have impairments in one or the other or both. So, I've definitely seen kids who present to me as phonological in terms of how their speech is impaired, but I do a neuromotor exam on them and they are all over the place. It's like, what is going on here? How can you do these things for speech, but not for non-speech? It just doesn't make sense to me that way, but I've seen it. I've seen it enough times that, I'll note it, but it is out there. But again, as we're talking about these non-speech movements, and we'll talk about it a little bit more later, I think it's just important to make sure that we are thinking clearly through the type of movements that we're asking and how they might impact speech or how they might not. the last thing that I wanted to talk about in the history was this idea of pop-out words. This is just kind of something that I'll say is from my experience. I have seen a lot of families that have a tough time answering the question, how many words is your daughter speaking? And they'll say, well, she says a lot of words, but we only hear them once and then never again. So if we made a list of all the words she's ever said, we're probably up to 100. But she said blanket the other day. My husband and I looked at each other from across the room and we said, did you hear that? She said blanket. We had her try to say blanket again, and she never said it again. These pop-outs, these things that can't be reproduced, just seems to come up in the histories of these kids that have several elements of difficulty in this area.
I've never heard the term pop-out word, but
I might have made it up.
Well, I think it makes a lot of sense. I mean, I have heard that described before, and that's obviously not a typical language development trajectory to use a word once and then never use it again. I think that's it's definitely something that I would imagine would be easy to uncover in an evaluation just through an interview, but also a unique characteristic worth noting for sure.
Yeah. And I think, as I'm hearing you describe it, I want to say that I don't know where it comes from. It could be purely linguistic, and there's so much overlap between these systems that, maybe it's a retrieval thing. But I have seen it enough times in kids who I am feeling strongly about motor deficits that I wanted to mention it. And who knows, maybe one of your listeners who does a lot of this too can chime in and tell me I'm not crazy, or that I am.
Please write us. Write us and let us know.
There you go. I'm drumming up business. The next part of a comprehensive evaluation that I'm concerned about is something that we touched on earlier, which is gathering information about language development. It is so important. Even though I'm looking at speech, I'm really interested in how the speech system is developing. I need to understand receptive language ability, expressive language ability, pragmatic language ability, because I am trying to make a list of everything that needs support. And then in the grand scheme of things, if there is motoric difficulty, where does that rank? And if I don't know the grand scheme of things, if I don't know that whole list, it's really easy for me to say, yeah, sure, let's work on motor speech. But at the same time, the clinician who is working with this child says, how am I going to work on motor speech when I've got to do these other 10 things first?
I was just about to ask you that question. So when you talk about gathering all of this information through an assessment and then thinking about where does it rank, which is, I think, the phrase that you use, is that because you're trying to determine using that ranking as part of the differential diagnosis, or is that part of what drives your treatment? In other words, you have an individual who you think does carry some apraxic, presentation, but there are bigger fish to fry. There are many other things that you need to work on. So is that ranking part of the diagnosis or part of your treatment plan?
That's such a good question. I think that it is more in the latter, in the treatment planning. I have had the opportunity to meet with a lot of families who have a child on the autism spectrum, where I could very well see a lot of symptoms of motor speech difficulty. And I am comfortable enough in documenting it. I am not comfortable enough oftentimes in suggesting that folks need to be prioritizing it in treatment, because things like functional communication, understanding the exchange that's kind of comes naturally to many other children, need, or even just readiness for participation, need to be prioritized before we're able to do anything else. And it's so hard for families to hear that, understandably, because this idea of apraxia has been dangled, has been mentioned. Maybe it's apraxia. And
this is literally this is a whole episode in and of itself. Yeah. I think it's such but it's a really important point. And I think the other really important point that you're making, and we've talked about this a lot before on this show, is the importance of comprehensive assessment. And the point of comprehensive assessment, the point of an assessment is to drive your treatment. I mean, so I think a lot of clinicians in thinking, okay, I'm doing this evaluation, and the point of the evaluation is this component of diagnosis, but that's not going to have the positive impact on the client. The point of your evaluation is to collect this information. Maybe a diagnosis is important from the value system of the family and something that you are going to do, but you are really collecting information to drive treatment, either treatment that you give or treatment that someone else is going to give.
Yep. And I just have so often seen it be a painful journey for families when they are still learning about all of their child's complex communication needs. That when they hear, hey, you got to go see Mike to see if your child has apraxia, and 6 months later, back when I was working at the hospital, that's kind of what it looked like. 6 months later, they arrive in my office to be told, yeah, maybe it's apraxia, and I don't think that it's all that important right now. That it is. People are understandably confused and upset when that happens. So I've seen it happen so many times, and I would just caution people to consider. It happens a lot in early intervention as well, because maybe it's apraxia gets dangled as a possibility when kids are not talking very much, or they are not making much progress. Maybe it's apraxia. And to say that to a family is going to send them instantly to the computer to put it into Google and to look up what is apraxia. I often, from time to time, put in this in my Google search, childhood speech difficulties, and Google comes up with these very helpful boxes. Lots of people are looking for this. Did you want to learn about childhood apraxia of speech? It's like the first thing that comes up. And we can talk about prominence or prevalence of childhood apraxia of speech later. But even on the ASHA site, where they are listing speech disorders, they do it alphabetically. So childhood apraxia of speech is much higher on the list than speech sound disorders, which are much more prevalent. So it's I think it does a disservice sometimes to say to a family, there might be childhood apraxia of speech, but I can't diagnose it. So we're just going to have to wait and see, versus your child needs some help with early communication. And I think it would be helpful to consider how the muscles are moving as we do some of that practice. One of them, I think, implies an awareness and a plan, and the other one just sends people into a tailspin. So I would encourage people to be careful around that.
I'm loving so much of everything you're saying, because my perspective is that this quote apraxia diagnosis does get sort of dangled, and clinicians, often don't know what to do with it. It's this unique sort of scary thing that, you need specific treatment approaches for, and there's specific training for it. But I love what you're saying about considering the whole child and and prioritizing the needs of the child. So maybe if it is apraxia, there could still be so many other ways to intervene, like functional communication and social communication, all those things to improve the life of the client, instead of getting hung up on this, not to not intervene for apraxia, but consider it in the ranking of all of the other things that are going on with the child. That personally, that resonates with me a lot.
Good. And I think
Thank you, Professor.
Oh boy. I think what you're making me think is that, and again, this is for another podcast, but in recommending that someone work on motor speech, you're not able to just sprinkle that in to a session here or there. It is a different approach. It's intensive, and it necessarily occurs at the cost of something else. So
can you say that again? I did like all the things. Yes, 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 yes. We're both like fist pumping in the air.
Okay. Yeah.
That is such an important point. And I hope everybody really lets that sit and marinate for a few seconds because it's so important.
Well, and we talk about that a lot on this show. It's just the idea that time is not a finite resource for anybody. And so when we're thinking about our treatment, I think using your sort of detective description that you brought up at the beginning is really important and relevant for everybody, whether we're considering childhood apraxia of speech or not. I think we should all, have our detective glasses on whenever we're doing our assessments, because we are trying to make those determinations, not just about what's going on, but about what, are the best choices when we're thinking about treatment, and what is the best way to spend time like it's money. Because it is, when we think about the schools, you're pulling time. Anytime that you're in speech, you're not somewhere else. Anytime, if we're talking outpatient, families are driving their kids to your house or, zooming in on Zoom. And I guess a question that I have kind of back to the assessment is just when you're doing this in-depth assessment, you're looking at all of these components. What are things that sort of make you think, yes, this is worth the time, money?
Yeah. So I think that it is going to be good to talk about all of the things that we're trying to snuggle into one single session assessment where we're answering all of these questions, because the clock is ticking. When you meet these kids, they may or may not be excited to see you, and you only have so much personality or fun toys in the box to get them to keep going. So it really is a matter of using your time efficiently. I am often using a single word articulation assessment like the Goldman-Fristow because it's helpful for me to know what sounds a child is producing in relation to what sounds they were intending. There's a relational analysis that I need to try to develop. Not only what sounds can a child produce, but what is produced in functional speech in place of something else.
We're chuckling because Amy loves these. Amy loves relational analyses and talks about them a lot.
Independent
off the air,
independent and relational,
or whatever. We're
going
to plug a future episode on these because this is a passion brain project of mine.
Okay. No, it's so important. Here. It's so important for diagnosis and for treatment planning. So there you go. Gotcha. You guys can't see it, but we've got a wiggle dance of happiness going on the other side of the Zoom screen. So I am trying to get the single word articulation, not so much for the score, but to try to establish these independent and relational inventories. And I like the Goldman-Fristow 3 because it has examples of all diphthongs, and those are often so important for me to hear how a child moves between sounds when that vowel is requiring such precise movement. Another tool that I find myself using more and more over the last couple of years is an assessment called the Dems, Diagnostic Evaluation of Motor Speech Skill. It was developed by Edith Strand and Rebecca McCauley. And what they've done is given children the opportunity to imitate increasingly complex real word sound sequences and the opportunity to gauge children's response to clinician cueing. So essentially, it's like the therapy that you would be doing and a standardized way of measuring not only ability, but response to support. Can the child imitate? If not, can the child improve her production with support? If so, can she maintain that improvement when the clinician fades the cues back? Each one of those things is so helpful in understanding how the speech system is working.
That sounds awesome. I had never heard of the Dems.
Yeah, it is new, and it is really hard to administer. However, it's hard in a lot of ways. Because you're tracking about 5 things while you're trying to cue a kid who probably doesn't want to be doing this. But I think it is also crucial to know whether a child has the ability or the stamina to get through something like that, if you're going to then recommend repetitive drill-like motor speech practice. So it's a good one, and if you can get through the manual and understand how to do it, you are right there with me as a professor in speech pathology. So once you've got your inventories and you've got a single word articulation measure, what I like to do is a lot of playing around speech sampling and diagnostic therapy, hopefully in free play when the child is feeling talkative, maybe towards the end of the session or in a break between measures once the child is more comfortable. My goal is, again, to fill out those inventories that I'm making, but I'm also listening for prosody, the intonation, the stress, the rate. I want to know, does the child have the ability to vary those features? Does automatic or highly practiced speech sound different than newer or more unusual productions? I'm often using structured play, something with reduced language demands. For instance, bubbles with a topic board or sentence strips that tell me to put the car down the tunnel, or an activity on the computer where the influence or impact of language retrieval is reduced because we're saying the same things again and again and again. And that gives me the opportunity to listen for some of that token-to-token variability in a context where I am more certain that any variation is motoric rather than linguistic. A key thing to note here is to consider length of utterance. When a child is just starting to speak in short phrases, I want to make sure that my motor speech assessment, the phrases or the word combinations that I'm having a child say, listening for token-to-token variability, are within a child's capacity. It would be not surprising for a child to exhibit some inconsistencies if I'm asking them to do something beyond their capacity. So if a child is using some short 2 and 3 word phrases, I want to make sure that that's what I'm asking her to do in my motor speech assessment. Does that make sense?
It does.
Yeah.
It also sounds very thorough and comprehensive.
Okay.
Mike, can you talk a little bit about the inventory, like what specific things you're looking at when you're playing the bubbles, you have maybe your topic boards out? What things are you listening for? Because we've done, I've done the Goldman Fristow. I think our listeners have probably done the Goldman Fristow or a similar assessment, and they know, you're looking to kind of transcribe their utterance, compare it to the target. What sorts of things are you looking for other than prosody, or I guess in addition to prosody, if there are any that you're looking for when they're...
Sure. So let's think about a child who is combining 3 and 4 words and is maybe able to say something like more bubbles or more big bubbles. I'm going to get my bubbles out. I'm going to be super careful not to get any bubbles popping on my face because, oh, geez, I just took a bath. So please don't make any bubbles pop on me, so that we get that motivation established for this kid to say more bubbles or more big bubbles, because the big ones really pop and make a mess. And then I want to hear that again and again and again, to listen for differences in how a child is moving between sounds. And so if I hear something like mo bubble, mo big bubble, mo bubble, mo big bubble, and it's sounding pretty similar both in the sounds used, the vowels, the consonants used, the vowels used, and the stress and intonation used, I'm feeling like this is a motor speech act that is within this child's capabilities. And and that would be what I would be expecting for a child at this level of language development. In contrast, if this child is able to say bubbles, 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 because bubbles is her favorite thing and she's always requesting bubbles, but when you ask her to do little bubbles or big bubbles. Again, all these words are in her inventory. She said them before, but when you combine bubbles and little bubbles, you get all sorts of variation, and it sounds different from time to time. Then I'm thinking, might those be, again, not linguistic or retrieval based errors, because we've got this visual topic board out there, but might there be evidence of motoric difficulty, or could I suggest that the errors or differences there are based in movement? And if so, then what? And maybe that's a good time to jump to the last part of an assessment, which is really giving feedback and sharing information with families. When you've done all this, you've done some standardized assessment, you understand a child's receptive, expressive, pragmatic skills, you've gotten a great independent and relational inventory, and you've done that analysis, you have to decide how confident you are in the fact that there is or isn't difficulty planning and programming that's primary in importance to this child's communication profile. I am rarely confident about this, and I do it all the time. It is tricky, it is hard. But when I'm not suspecting childhood apraxia of speech, and when that's clear, I am sharing that. And I let families know that this is in general a pretty positive finding. You'd be surprised how disappointing it is to families, often because they've been set up for disappointment in this way, but that they hear, I don't think your child has childhood apraxia of speech. I think the difficulties are in another realm. How it can be hard to take sometimes. And I think that it's important to share, rather than this motor speech approach. I think this other approach is going to be a really good way to have people spend their time in therapy. And that tends to be helpful because if it's not childhood apraxia of speech, what is it? We need to discuss what is phonology, what is language development, what is pragmatic language. If I am thinking that childhood apraxia of speech is definitely a component, I want to establish with the family an understanding of what that is, what that means. And as you can tell from the last hour of us talking, that's really confusing. I'll often try to use an analogy like trying to find a scarecrow in a giant field of corn, a giant cornfield where you're on the outside and you can't see where that scarecrow is because the corn is so tall. Where is that scarecrow? The more times you walk from the outside of the field into the field, matting down that corn and getting toward that scarecrow, the easier it is to find it. We're establishing pathways, motor pathways, by walking through that field again and again and again. We don't want a lot of scarecrows in that field because when we're practicing different speech movements and we have 10 targets that we're practicing, or we're using the whole super duper deck, we are not getting that same motor practice and developing pathways in the same way. And it's important for families to understand this so that they know what types of therapy are going to be appropriate and how to identify something that might be a little bit off. The last thing that I want to share is just, again, this idea that I'm so often in this space of thinking, yeah, maybe it's apraxia. And maybe I want someone to really take this on as a project for the next 6 months and to try out some of these principles of motor learning and integrate them into speech therapy. And then I want to see you back in 6 months and we'll do another assessment and we'll have more information at that point. And maybe we'll say, hey, these motor concerns that I had initially have really faded away. And now it's much more clear that we're talking about something phonological or linguistic, or you know what? Even with that focused attention, it's these motoric concerns that are the greatest for me. And I want to make sure that we're really prioritizing those in therapy.
I have so many more questions and we are completely out of time.
Inadequate amount of time for the conversation.
I feel like everything you just said speaks so much to not only, your level of expertise, obviously, but in terms of, counseling the family or, what your level. So you say that's the whole title of this. Maybe it's apraxia. So I'm going to recommend how many hours of speech therapy. I mean, I know that we haven't even gotten into some of the recommended treatment protocols and procedures for this particular diagnosis and area of deficit, but I can't say enough how grateful I am to you for sharing all of that, because I think it's a unique area. And now I just want to know more.
Well, I like talking about it. So if folks want to chat more about it, I'm always up for it. And people can actually email me directly, mikebrightspeech@gmail.com. I'd love to chat. I'd love to meet
He's
more
really
kids.
the most friendly human, everyone who's listening. He will answer your questions if you email him questions.
Yeah. And it is, I recognize how confusing it is. And am often in that confused space myself. So because I'm so familiar with it, I am really appreciative of the opportunity that you folks are giving me and that other people give me when they think of me as a resource. So thank you.
Thank you.
If everyone is listening out there, all of the there are going to be some references and resources in the episode notes that everybody can list. We will list Mike's contact information and a little bit more about him on our website that listeners can reference. And Mike, we're just so grateful for your time. Thank you so much for joining us.
You're very welcome.
Anybody who wants to use this episode can go onto our website and use it for ASH's CEUs. If you have questions about that, you can email us anytime at info@slpnerdcast.com. And thank you so much for sticking with us today. We hope to hear from everybody soon.